All right. So I have just started the recording of this CAC meeting in compliance with CMS. For the record, prior to doing so, I did announce that Palmetto GBA would make an audio recording of the CAC meeting and consented on behalf of Palmetto GBA. So I believe we're ready to go. Thank you so much for all of you being here. So our first questions have to do with sort of general with MIGS procedures as in general, if you could help enlighten us a bit. So my question to all of you is, how do you define failed medical management for glaucoma? And when does it warrant a MIGS procedure? So why don't I just start with Dr. Sola-Del-Val, if you would.
Hi, Lisa. How's it going? Can you hear me?
Yes, I can. Thank you, David.
Yeah, I think Jeff and the group, we met, decided we're going to try to tackle the questions. We're going to tackle certain questions, and then at the end, I believe Pradeep and Emily, we're going to take. Correct me if I'm wrong.
Had a little difficulty hearing you there. I think I heard that Pradeep was going to take this one.
Pradeep, yeah, Pradeep and we're going to take this set of questions, and then we can all chat at the end if needed.
Sure. Yeah, no, I'm happy to take it. So thank you for having me. I'm Pradeep Ramalu. So, failed medical management can refer to either a pressure which is elevated, which risks further glaucoma progression, or evidence that glaucoma progression is happening, with the medications maximally used. In other words, that all medications or nearly all of the medications that the patient could have been tried on the patient have been tried. When does it warrant a MIGS procedure? I mean, that's a very complicated question. I mean, I think the question itself, first of all, is maybe a little bit kind of implying that a MIGS procedure is only warranted when there's failed medical management. And I would say that, that there is evidence that from the Horizon trial that actually pressure which is lowered surgically with one of the MIGS devices, and that trial actually prevented glaucoma progression better than the same pressure that as measured clinically by cataract surgery alone and medications, indicating that probably surgical control is actually controlling pressure on a more consistent basis. And so there is evidence for better visual field control with MIGS and prevention of glaucoma damage. When does it warrant a MIGS procedure? I mean, that's a complicated question. It depends on whether there's coexisting cataract. It depends on, at what rate the patient is progressing. It depends on the severity of disease. It depends on, the kind of their comorbid conditions, including, what systemic medications they're on. It depends on the status of the other eye and how that eye is in terms of its severity of damage, and how it's responded to various therapies, both medical and surgical. It depends on the type of glaucoma, whether it's open angle or closed angle. I'm not trying to be evasive. It just, I think the answer is just highly dependent on the individual factors for the patient. And so it's really hard to kind of give you a straightforward, simple answer of exactly when a MIGS procedure is indicated or not.
Okay, and who else did we have that was going to weigh in on this one?
This is Emily Jones. I was going to weigh in on this one too.
Hi, Emily.
Hi. Did you have a follow-up question?
No, I'd like your take on this as well, if you had anything more specific to answer to that.
I think Dr. Romelu answered it very well. I think as far as when you would use a MIGS, he was mostly comparing it to continuing to manage a patient on medical therapy. And I think maybe the one point he didn't explicitly touch on is that the MIGS procedures overall are considered to be much safer than traditional glaucoma surgery. Things like tubes and trabeculectomies, which used to be our only option for patients who weren't tolerating medications or who showed evidence of progression on their medications, have a very significant risk profile. And the MIGS procedures in general are much safer for patients with a lot less potential for vision-threatening complications.
Yeah, if I could maybe expand on my prior answer a little bit too. I mean, there's maybe, two big areas where MIGS are used. One as a standalone procedure where maybe then you are doing it when the patient is you're not happy with the medical treatment of the patient. And then also when another surgery is already indicated, typically when cataract surgery is already indicated, and then you're considering a MIGS device. With the evidence that we have from the Horizon trial, I think it's become very appealing and almost the standard of care that a patient be offered a MIGS procedure at the time of cataract surgery if they have manifest glaucoma or if they have very high risk of glaucoma progression, even if they don't have manifest